disorders, right? No. Okay. We talked about punch-out, by proxy. Which one would be associated with child use?
By proxy.
By proxy. That's when we're causing symptoms in a child or other dependent. Could be a dependent adult. Could be a dependent animal. Okay. I think this is around where we left off. We were talking about conversion disorders versus somatic symptom disorder. And as you guys were listening, somebody had a question, and so I wanted to make sure that this got explained. Okay. Conversion disorders are kind of like an overall topic, and then under them is monetization and those pain disorders. Okay, so this is kind of like more of like a general topic. So as we go through, we talked about how it's like physical symptoms, but there's stuff that's kind of off. For instance, if you had numbness and suddenly you had your entire arm or your entire hand go numb, is that how medically things usually happen?
No.
What would probably go numb?
Just your pinky finger.
Only one side, because that would follow the nerves, okay? So it either would follow the radius and a radial nerve, or it would be like just these two fingers, which have your whole hand go numb. Doesn't really fit with what we know about medical stuff. And then it's more likely a conversion disorder. So, I think we left off around here, talking about somatic symptom disorders and the somatization pattern and predominant pain. The somatization pattern was the one we talked about where people have pain symptoms. It could be joint pain, muscle aches, neck problems, gastrointestinal. What's gastrointestinal?
Stomach.
Stomach, GI. Okay, so anywhere in the entire digestive tract. So it could be difficulty swallowing, difficulty eating, something wrong with your tongue. It could be esophagus stuff, it could be intestine stuff, stomach stuff, stomach ache, stomach upset, constipation, diarrhea, throwing up, everything you can imagine a Pepto-Bismol commercial, okay? So that's GI symptoms, sexual symptoms, and then we talked about neurological symptoms and watched the video, yes? Of a young lady having seizure-like symptoms. And we decided she looked like she was having a pretty good time. Yeah, she looked like she was having a terrible time. And did this look like something people would do on purpose? Yeah. It's very much like a medical seizure. But when they run tests on someone with somatic form disorder or somatic symptom disorder, even while they're having these seizure-like symptoms, does their brain show that they are having a seizure? No, the brain does not show like they're having a seizure, but they're still having those physical symptoms. Does that make sense? I know this is our first disorder, kind of class of disorders that we talked about, where these get a little bit rare and it gets a little bit more removed than probably what you've seen in your usual life. Most people have had some sort of bout of minor depression, a little bit of nervousness, anxiety, and I think those disorders are easier to connect with. When we start going into stuff like this, it's a little bit harder to kind of hold on to this. So I suggest if you're having trouble, read through your text. Okay, that can really help you guys hang on to this. Patients often go from doctor to doctor to doctor in search of relief. Why do you think that is? Yes, ma'am.
Because some doctors can't really find a diagnosis, or they either think it's fictitious.
Yeah, so if I went to the doctor and said, help, I'm having a seizure, and they ran an EEG and checked out my brain and said, oh, no, you're not, what's going to be the conclusion? You're just faking, you're just making it up. Is that doctor going to be happy with you? No. They're going to say, you're wasting my time, wasting everybody's time, get out. And then how do you feel as a patient?
Bad.
Bad, right? Because are you faking this or making this up?
No.
No. This seems like a scary disorder. And having medical professionals tell you, oh no, this isn't real, this isn't happening, has to be, what do you think? How does that feel?
Confused.
Confusing? What else? Like helpless? Helpless? Would you be a little bit cranky about it?
Mm-hmm.
I would be mad that no one was taking me seriously. Might you start also doubting your own sanity
Mm-hmm.
and think maybe I am making this up? At some point, you might start to wonder. So usually, folks with somatic symptom disorders have gone from doctor to doctor to doctor. A lot of times what happens is they'll first go to who do you think? Where do you think people start out? The ER and or would be another doctor you might go to. Just general practitioner, your regular old doctor. And if they don't want to be rude and say, hey, we ran tests and nothing's wrong with you, you're probably just a liar, what might they do? Refer you to a specialist. And so a lot of times people get passed around from specialist to specialist to specialist, and they probably not had to spend any money, right? Seeing all these fancy doctors is free? No. Sometimes they spent hundreds of thousands of dollars. So it's important to remember, by the time you see this patient in your office, have they probably gone through the ringer? What's their attitude probably like? Happy, excited, can't wait to see you? Or you think they're a little bit cranky?
Cranky.
A lot of it cranky, okay? Because they've gone from doctor to doctor to doctor, had all these tests, and spent all this money, and people have accused them of faking and lying, and no one believes them. So the time they get to your office, they're pretty ticked off. And that's important to remember when working with patients with somatic symptom disorder. Okay? The somatization pattern with the, go on in, have a seat, do what? With the neurological symptoms, the pain symptoms, the GI, the sexual symptoms, all that good stuff. This pattern is far more common in women. And it often runs in families, and we see this starting to develop in young adulthood, early adolescence. Where are we hanging out then? High school, okay, that's usually the first place we start seeing this. We also, it's really interesting because the pattern seems to just hold together. I've had multiple patients with this diagnosis, somatoform disorder, and it's like, are you sure you guys aren't sisters or twins or cousins? Because I've had 3, 4, 5 people, and they have all the exact same symptoms. They all have the same kind of issue with their neck. They all have the same sort of issue with gaining or losing weight. They all have the same ringing in their ears, and have been told they might have endometriosis, and been told they might have autoimmune. And it's really similar pattern. It's also important to rule out for autoimmune. Do you guys know what autoimmune disorders are? Yeah. What's like some big popular ones? Which one? Sort of. MS is sort of an autoimmune. It's the nerves are like getting attacked. Another really common one is lupus. You guys heard of lupus?
Mm-hmm.
You guys remember that show House? And they're always like, it's never lupus. Sometimes it's lupus. Okay? Lupus is a strange autoimmune. It's often hard to detect for years. Even when people are given quote unquote the test to detect lupus, a lot of times they don't have the right antibodies, and so they can't test positive, and they're struggling with symptoms. Another one that's pretty common is Hashimoto's disease, which is another autoimmune. So that's something that's important to rule out, because a lot of these symptoms can be related to autoimmune. They can also be related to MS, and they can be transient, where they're there for one day, and then by the time you go get a test, they're gone. So that's an important rule out. But once you've done that, and we've run all the tests, it's not autoimmune, we're not having seizures, then we say, ha-ha, I think you have some sort of conversion disorder and a somatic symptom type effect. So one pattern under conversion is the somatic symptom disorder, or somatization, and that's the one where you have to have the neurological, the pain, the sexual, all the different symptoms, okay? Or we can have just predominant pain disorder. With predominant pain disorder, we usually have had some sort of injury. So maybe someone has a sports injury, or they were in a car accident, or they fell and broke a bone, okay? Or they've had some sort of injury to their back. They usually had some sort of accident or illness that did cause general pain. And then after that, they should have healed, but the pain is still there. Anybody ever break a bone? Yeah. What'd you break? Your wrist, okay. Did it hurt? How long did it hurt? Like a few hours, okay, and then you went to the doctor or something, and they did like an x-ray and a cast, and then how long did it take to heal? Month and a half, okay. How many years ago was it? 5 years ago. Does it still hurt every day, all day long, like when you first broke it? No, because the bone is healed and the damage is gone. When you get older, if it hasn't happened yet, it might happen, some people get. When it's cold and rainy like today, some people get a little bit of, a little tender, their arthritis acts up, okay? But it's usually sort of a reactionary thing and not all the time. With pain disorder, instead of breaking your wrist, healing, getting better, and moving on and saying, hello, I can go back to life, the pain doesn't stop. So instead of having a month of pain, she might have 5 years of pain, where every day she has pain in her wrist, or her arm, or her back, or her head, or her neck, like she just broke it. Excruciating pain. And so you go to the doctor, and they're gonna run tests, and what do you think they're gonna find? Nothing. Not a gosh darn thing. And they say, we're sorry, there's nothing wrong with you. And you say, but I'm in so much pain. And they say, no, you're not. And so they can check the bone, they can MRI, they can CT scan, usually do all kinds of different checks and say there's nothing there, there's nothing there, there's nothing there. Sometimes people will even have invasive surgeries where they'll go in and try to clean out joints and shake things down and try to look for scar tissue and bone spurs and all that kind of stuff. And they do that, and does it fix it? No. People are still in pain. Okay, this could start at any age, and it's more common in women. Okay, what makes all this stuff happen? We got a couple different views. We've got a traditional psychodynamic view, that's sort of that Freudian stuff, and this is the idea that if we have something going on in life that's too overwhelming, okay, I have too much anxiety, too much pressure on me, I'm too sad, I'm too angry, I'm too whatever I am, and I literally can't even, the body takes over and says, you know what, I got this. And it makes symptoms to help get us out of uncomfortable situations. So, if you have a really bad headache, what happens? Really bad headache. You stop doing your activities, okay? So, the first thing that's going to happen is you're going to stop doing your activities. If you were worried about something, like let's say you were worried about a test for school, or a big sports event, or a problem in a relationship, fight with your friends, mom, dad, dog, whoever you're into it with, are you still thinking about that, or are you just kind of focused on your really bad headache? Where's your attention go? The headache. So the primary thing is you stop worrying about whatever your problem was, because now you're overcome by this really bad headache. With somatic symptom disorders, often it's way worse than headache, okay? It's, I can't walk. I wake up in the morning and now my legs don't work, or I'm hysterically blind. And so people are forced to stop thinking about their problems because they're all focused on whatever this somatic symptom thing is. Secondary issue is, if I can't walk, can I go to school? If I can't walk, can I go take that exam today? No. What if all of a sudden I get terrible, unbelievable, excruciating pain in my wrist that I broke 5 years ago, right before my exam? What am I probably going to have to do? Now I have to email the instructor and say, everything's terrible, I have horrible, horrible pain in my wrist, I can't possibly hold the pencil, I can't possibly take the exam. So what happened? Did I get out of something? Yeah, so I don't have to worry anymore because I'm thinking about my wrist that hurts instead of my problems. And secondary gain, I got out of whatever it is I didn't want to do. Does that make sense? So there's two different factors reinforcing this. When we go to a behavioral view, from other disorders we talked about, and behavioral view in general, we said when stuff gets rewarded, we do it more, we do it less. More, okay? So much like the primary and secondary gains of the psychodynamic view, with the behavioral view, again, we have this reinforced. The individual may not have to that unpleasant situation, I don't have to go to school. I don't have to take this exam on the very worst about. I don't have to go do tryouts for baseball. I don't have to go have that tough conversation with my dog trainer. Secondly, what did we say happened when we were kids? We have to stay in bed with the jammies, eat our chicken soup, drink a soda, watch our cartoons. And what do mom and dad do? Baby you, and you post on Facebook or Instagram or Twitter or whatever, help, or whoever, and what does everybody on Facebook say? Too bad, tough luck, hope you feel better, oh, I'm so sorry. That's terrible, sad face, all kinds of fun emojis, hearts, and stuff like that. Okay. Maybe you suck yourself. You get old. Right now. You know what that's made of. Okay? Yeah, we might get a lot of attention from other people. So, is this rewarding? Yes. One, I removed the negative thing I didn't want to do. Two, I get warm fuzzies from everybody. So yeah, is this going to be a reinforcing thing? If my body says, oh no, you have a headache, oh no, your wrist hurts, oh no, you can't see, and I get out of the thing I didn't want to do, and everybody says, oh, poor you, comfort, 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 what's my brain going to think? Was this a good idea?
Mm-hmm.
Yes. Is my brain going to do this again?
Mm-hmm.
Yes. So it's a reinforcing. This is very similar to the psychodynamic model, yes? Do you see the similarity between these two things? So just in case you, I don't know, ever had to have an exam in this class and compare these two models, you'd be able to do that, right? Yeah, okay. Good. Yeah, okay, here's the exam. We also have the cognitive view. So we had behavioral, cognitive. When we're talking about cognitive, what are we going to be talking about? Cognitive is what? A thought. So we're talking about how the way people think might affect it. For the cognitive view, conversion disorder, somatic symptom disorder, pain disorder are just another form of communication. It's providing a means for people to express very difficult emotions that they don't have the words for. Have you ever had somebody tell you something very shocking, very surprising, bad news, and you just don't know what to say? Someone tells you, I just broke up with so-and-so, I just found out my dad has cancer, I just lost my job, and what are you supposed to say? I'm so sorry. What else can you say? That's about it, and then you're kind of just stuck. Right? And sometimes people don't know what to say. And they just kind of go, I don't know what to say. And so this is the idea with the cognitive view, is that sometimes people don't know how to express things. Especially when emotions are very confusing. Sometimes this happens to us with like frenemy stuff. Okay, when we have a friend that's kind of this weird love-hate relationship, or when you do the breakup makeup thing over and over again, and we get kind of weird, it's complicated status on Facebook, we have a hard time explaining these things to other people because we don't have verbal words to say this is what's going on, this is how I feel. The cognitive view is this is what's happening to people with somatic disorders. They don't have the emotional vocabulary and they don't have the words to communicate these really big feelings. So instead, their body is trying to communicate it for them in a physical type language. Their emotions, their thoughts, their big feelings are being converted into them used as communication. That's different than yeah. So if you were going to pick from somatic, psychodynamic, behavioral, or cognitive, which ones are similar? Behavior and psychodynamic. Which ones are different? Cognitive and the other two. Okay. Cool. We've also got a multicultural view. And this basically point of view, the idea that this is just communication and that it's normal in all other societies except for Western. If you say, I am sad, somebody died, I broke up with somebody, I lost a job, I just been on my head, I feel bad. And not only do I feel bad with words and emotions, my body feels bad. And that's just part of the experience. Is anybody from a culture where that's something that you say, yeah, that's something we do? That you notice when people say, I feel bad because they're upset because someone died, like really upset, not like, oh, bummer, they were out of mocha sauce at Starbucks, like big bummers. Do you notice that people tend to have physical symptoms with it? Yeah, what cultures? Which ones? Hispanic, yeah, okay, absolutely. We'll see this a lot in collectivist culture. Very common in Hispanic culture. So if someone dies, we don't just say, oh, that's sad, that's terrible. What happens, usually more to women than men. Mom or grandma or aunt might end up where? Hospital. But before they go there, where are they hanging out in the house? In the kitchen, making breakfast? No, they're where? In their room, in bed, laying down. Okay, I'm sick, I can't deal it. Sometimes they end up in the hospital. You're after death of family, specifically in Hispanic culture, that mom, aunt, grandma might have a stroke, might have a heart attack, might have some sort of other physical thing act up in their body and end up having to be hospitalized. Okay, and we see this throughout a lot of non-Western cultures. Okay, how are we gonna fix this? Should we just leave these folks alone, or should we help them out? You guys are just gonna leave them alone? You guys are rude. You wanna help them out? Yeah. You're gonna help them out? Okay, you're gonna help them out. Okay. So, yeah, how should we help these people out? There's a couple different ways to treat this. We can focus on the cause and use sort of an insight, psychodynamic-oriented approach and help them figure out what is going on in your life that's so overwhelming that you can't face. And if we could fix that problem, should the symptoms go away?
Yeah.
Yeah. So that's one approach. We can also do some exposure type therapy, okay? And get the client to think about the traumatic event that triggered these physical symptoms, be it taking an exam, performing in some sort of sports thing, facing a person and having a discussion in a relationship like a breakup when, I don't know if I want to do that. Maybe talking to a boss, coming out to your parents, something like that can be very overwhelming, okay? And we can get you exposed to that and say, let's practice here in therapy, and then what can we do after we have them talk about it? When they get very anxious, what do we want to do?
Drugs.
Relaxation, okay? And so we can do sort of a systematic desensitization and or an ERP. Remember what ERP was? Exposure.
Relaxation therapy.
Response prevention, okay? So some sort of exposure treatment. Flooding, do you think that's going to work?
No.
Probably not. This is probably not a good time to do flooding. Because if we say, oh, your legs don't work, well, we'll just throw you out in traffic and see if you can run. Probably not a good idea. Okay. Also, drug therapy is helpful, particularly antidepressants, which we found out for these classes, we use antidepressants for almost everything, yes? Yeah, find out with stress antidepressants. So some Prozac, some Lexapro, stuff like that. The other option is to focus on the symptoms, okay? And who do you think, what orientation do you think would follow that? What model? Would say, we don't care why this happened, we're just going to focus on the symptoms.
Psychodynamic.
Maybe bio, what's the other one? Behavioral, yeah. So bio and behavioral say, we're just going to focus on the symptoms. Who do you think is going to be more of the insight type stuff?
Psychodynamic.
Psychodynamic, anything else? Cognitive, yeah. And that's going to be the response there. When we're focusing on the symptoms, we might use hypnosis or mindfulness. So when someone feels they start getting the numbness, the tingling, the getting dizzy, the head pain, we can have them do mindfulness type exercises to help bring them back. We can reinforce when they have non-conversion symptoms. We can come up with rewards for them in life so that we can get them out of bed, situation. We can try to do confrontation and attempt to force them out of the sick role, and that would be the throw them out in traffic thing. That is the flooding. That's pretty risky. I wouldn't suggest that, but that is a behavioral approach that some people might use. I would not suggest that, okay? I was watching, what was it? Was it The Flash or these heroes? I think it's The Flash. I think that's The Flash. With the, what's the name? Hawk Girl? Okay, and I was thinking about this lecture, right? Okay, because Hawk Girl, she doesn't know she's Hawk Girl. Spoiler alert. You seen this business? Okay, and Hawk Girl has these big wings, but she doesn't know that she has them yet because she hasn't like emerged as Hawk Girl. So she thinks she's just some chick that works at like their Starbucks, right? Okay, the coffee shop. And so this other guy that's all, hey, I'm Hawk Girl. He decides he's gonna help her, and guess how he decides he's gonna help Hawk Girl? Takes her up to the top of the building. Pushes her junk off because he says, well, we'll just freeze her out and confront her in this, and if I push her off her building, she'll just magically grow wings and fly away. Does that sound like kind of a risky thing to do? Yes. Thankfully for Hawk Girl, guess what happened? She did have wings. Phew, and she flew and it was great. Thank goodness, okay? Look, this has gone very bad. Yeah, okay, so confrontation, I wouldn't suggest it, but some people use it. Okay? Questions on those? You guys have probably heard of this next one, illness anxiety disorder, under another term called hypochondriasis, or probably the word you guys have heard is hypochondriac, yes? You have somebody in your life that is a hypochondriac, or maybe you've been accused of being a hypochondriac. What's a hypochondriac?
They think they have an illness they don't.
They think they have an illness that they don't. Just one time and they're like, I'm over it. No. Is it sort of a pervasive pattern, like often?
Mm-hmm.
Yeah. So these are people that could be in your own life, could be you. That every time they get a little bit of a sickness, they have just a couple symptoms, they freak out and they have Ebola. Okay? I have a cough, oh no, it's the Zika virus. And they make extreme reactions to little symptoms and different kind of body signals. We no longer call this hypochondriac or hypochondriasis, we call this illness anxiety disorder, because DSM-5 is all about having everything end in disorder. I don't know why they just did. This is chronic anxiety about health. From the outside, these people just seem annoying. Yes, because it's like, oh, you don't have Ebola. Shut up already. They just seem annoying. They might be posting on Facebook about different medical things. From the inside, they are living in terror. They are constantly afraid they are going to die a horrible, painful, long, wasting death every day, all the time. So they have a huge amount of anxiety. They're concerned that they're going to develop cancer. They're going to develop some weird blood disorder that no one's ever had before. And it's going to be painful, it's going to be awful, and it's going to be terrible. They repeatedly will check their own bodies for rashes, for sores, for cancer spots. Sometimes they'll actually even injure themselves by pushing on a spot on their face that they think might be a cancer, or messing with a part of their skin that feels rough, and they actually will create an injury from checking it so much. Okay? Some of them understand that their worries are excessive. I saw somebody a couple years back, and they first were concerned that after a night of unplanned dating, we'll say, okay, and unprotected sexual contact, they were afraid that they'd become pregnant. So, if you were afraid you'd become pregnant, what might you do? Take a pregnancy test. So this individual did, and it came back negative, but they couldn't accept that. So they took another one, and then another one, and then another one, and another one. And they all came back negative. Would that be enough to convince most people?
Mm-hmm.
This was not enough to convince this person. So if you've taken a bunch of home pregnancy tests and you don't believe those, where's the next place you're gonna go? The doctor, which is what they did. So they had to do the clinic, and they said, help, I think I'm pregnant. They said, okay, go ahead and pee on the stick. No, you're not pregnant. And would they believe it?
No.
Nope. I need a blood test. They said, okay, here we go. We're doing the blood test. Here is your results. You are 100% not pregnant. Did they believe it?
No.
No. Okay. So they went to another doctor and had another urine test and another blood test. And guess what the results were?
Negative.
Negative. Did they believe it?
No.
No. Okay. So then they ended up going to the emergency room at one point and saying that they had really bad stomach pain because they were trying to get what, do you think?
Ultrasound?
A pregnancy test and
Ultrasound? Ultrasound?
an ultrasound. So they went and they did an ultrasound and they said, we don't see anything going on. And they said, by the way, am I pregnant? No, there's nothing in there. There's just darkness. There's nothing going on. Did they buy it? No. Totally convinced that somehow they were pregnant. Maybe, ooh, could be an ectopic pregnancy, okay? It's not in the uterus, it's in the tube. And what's going to happen with an ectopic pregnancy over time? It's going to rupture, right? And then what will happen? You could die, horrible pain. Okay, so now we're convinced we have that. So we go to a gynecologist. We get another procedure. They keep checking. They're finding nothing. Nothing. This goes on. This person continues to worry. At 10 months past the incident, can we continue to worry?
No.
Okay, so 10 months, we're still worrying though. And everyone's saying, okay, if you were pregnant, you should have had what by now?
A baby.
An actual baby. It would have walked out by now, okay? And they said, well, I read this thing online. Sometimes the people, that there used to be that show, I didn't know I was pregnant.
Yeah.
Okay, maybe that's me. And then it's like 10 months, 11 months. A year later, can we still buy this?
No.
No. Okay, so a year later, okay, I guess I must not have been pregnant. Or maybe I was pregnant and I had a miscarriage and I just didn't notice it. And so then the new obsession was, maybe I didn't get pregnant from that incident, but what could have happened? I could have gotten what? STD. So now this individual is obsessed that they have an STD. Specifically, that they have HIV. And so then they contact the person they had unprotected sex with and say, kind of half psychotically at this point, because they've been working themselves up for over a year, how dare you, oh my gosh, you gave me HIV. And what does the recipient of this phone call say? What? Wait, who are you? Because this has been how long? A year. I haven't heard from you. Yeah, okay, I vaguely remember that sort of. Wait, what? I had no idea. I better go get tested. Yeah, you better, because you gave me something. So this person goes and gets tested, and what are their results?
Negative.
Negative. And so they call this person back and say, you're bugging. There ain't nothing. I'm fine. Okay? And this person is obsessed that they have this STD, and it's driving them insane. They're crying all the time because is HIV something you typically get better from?
No.
No. Basically, a death sentence, and this person has it. Okay? And so now they are obsessed that they have HIV, and they are dying. And no one believes them. And they keep taking tests, and the tests keep coming back negative, and they see doctors, but they just cannot get it out of their head, this obsessional thought that they have this disorder. Any other disorders we've talked about that kind of sound like this? OCD, similar, very related. People might even have compulsions that go along with this worry. Often the compulsion is going to the hospital, going to the doctor, checking the body for sores. They might own like a home, maybe grandma or grandpa have one of these, like a home blood pressure monitor thing.
Mm-hmm.
Okay, and so they might take their blood pressure 6, 7, 8, 9, 10 times a day, and that helps calm them down. I felt my heart, it did something weird. I know it did, it's gonna blow up. I better take my blood pressure. What's my pulse gonna be at this moment? If I took it, I'm all freaked out. Really high. Oh my gosh, my pulse is 92. I knew it. My heart's gonna explode. Take it again. We've just pumped up on our arm, and now we're gonna do it a second time. Let's count the blood pressure. It's 1 million gravity, right? Okay? It's 150 over whatever it is because you just squeezed her arm and made the blood pressure really high. So these poor folks will just really send themselves into quite the tizzy. And this is illness anxiety disorder. Are they making this up on purpose?
No.
No, this is something their brain is telling them. The young woman that I worked with that couldn't possibly have been pregnant and totally didn't have HIV. Part of her brain knew this, and she was able to communicate that. That's why she sought therapy. She said, I know this sounds crazy. Part of her brain was aware. Different part of her brain kept saying, maybe, could be. Have you thought about? Does this sound like a frustrating disorder to have?
Yeah.
Yeah, not fun at all. Okay? It can begin at any age, most often in early adulthood. Where are people hanging out usually in early adulthood? College. So very common in college kids. This is an equal opportunity disorder. Men and women experience it the same. For most people, symptoms are going to rise and fall over the years. Okay, and tend to rise and fall with stress levels. So in times of more stress, what do you think happens to my illness anxiety disorder? It gets worse. When stuff's pretty okay and life's fine, my symptoms go down. Okay? What makes this happen? We don't know. There's behavioral ideas and the kind of classical conditioning is the same ideas behind OCD. The cognitive view is it's similar to kind of generalized anxiety disorder, panic attack thing, that there's an oversensitivity to body symptoms, that these folks are able to register slight changes in temperature, blood pressure, heart rate, other system changes in the body, and it's signaling a panic to them. Treatments are going to be similar to that of OCD. Antidepressant medications, so we're going to do Prozac again, exposure response prevention, the ERP, and or cognitive behavioral therapies. Questions on this one? We're leaving conversion disorders and moving to, I gotta sit back so I can't say it, psychophysiological disorders. This is where the brain and the body meet and get together and make a mess. This is a group of completely physical illnesses resulting from completely biological causes interacting with psychological and sociocultural factors, meaning your brain is making them worse. These are real disorders. So unlike factitious disorders, they're doing real damage to the body. You can actually die from these because your brain is helping your body to tear itself up. These are the big common ones, okay? Ulcers, what's that? Like holes in your stomach somewhere in the GI tract. What's it caused by? Too much acid, why? Could be what? Could be because of anxiety. If that's a psychology thing though, so throw it out. Do we know, within the last, let's say 15 to 20 years, they found out something really specific called clogged ulcers. They found out that there's, like, imbalance of the proper bacteria, okay, your digestive tract can cause it. It's sort of like an infection. And so then they came up with prescription medications to take to help ulcers. But anxiety also makes it worse, and it raises how much acid you have in your system. And that acid does what? What does acid do? Burn. It literally burns holes in your digestive tract. Being more anxious makes this disorder worse. Asthma. Anybody got that? What's that do?
Shortness of breath.
Shortness of breath, okay? This is a biological condition. It can be caused by allergies. It can be caused by restrictions of the lungs or the bronchioles. It can be caused by cold weather. It can be genetically inherited. And it can be worse under stress and anxiety. Anybody notice you have breathing asthma stuff? It gets worse when you're stressed out.
Yeah.
Yeah, okay. Insomnia, what's that?
Sleep.
They can't sleep. That can be caused by issues with neurotransmitters, with melatonin, sleep-wake cycle, all kinds of stuff. How easy is it to sleep when you're all stressed out?
Hard.
How do you sleep before a big exam?
No.
How do you sleep before the first day of school? How do you sleep before a big interview? That, because stress makes insomnia worse. Chronic headaches and migraines, are those fun?
No.
No, they're terrible. They can be caused by hormones. They can be caused by blood pressure. They can be caused by capillaries in your brain freaking out for no good reason. They can also be made worse by stress. What's hypertension? High blood pressure. Okay? Lots of different things cause high blood pressure. Being overweight, smoking, drinking, having a genetic predisposition, diet, all that stuff. How about stress?
Yeah.
Yes, it can make it worse. And coronary heart disease is just like hypertension part 2. When we have hypertension for a very long time, we can get coronary heart disease, where we get problems all over the entire circulatory system. Okay? Questions? Wednesday, we will finish out. Was that paper just the first draft?
Stopped
or was that
on
the
PowerPoint 20.
Friday? Yeah, that was the first draft.